I'd like to first thank the course organizers of the MAGIC Conference and Castle Biosciences for the opportunity to speak to you today. It's an exciting time in the world of Barrett's esophagus and esophageal cancer. And today we're going to review some updates in screening and surveillance for Barrett's esophagus in 2022. This first slide is a real patient who had a screening or surveillance endoscopy prior to COVID, and this was a very innocuous looking non-dysplastic Barrett's who subsequently got scoped a little bit delayed, but not out of the interval of a 3 to 5 year surveillance, and was found to have this nodular adenocarcinoma. And this will highlight some of the things we're going to touch on around risk stratification, and could something have been done for this patient despite a diagnosis of just non-dysplastic Barrett's that might have stratified the patient's risk to develop an aggressive cancer like this in a short term. We're all very familiar with endoscopic eradication therapy, and we're not going to talk about the details of this today, but this slide has a purpose. We become excellent at treating Barrett's esophagus and Barrett's-related neoplasia, whether it's EMR, RFA, cryotherapy, and the bottom line here is that we can achieve 90% complete eradication of disease with a very low recurrence. And this is a piece of information I want to use to set the table for why we need to really focus on some of these updates in screening and surveillance, because it's going to come down to a denominator that we need to increase to bring to this table where we can eradicate this disease. So why can't we find the needle in the haystack? What are the goals for screening and surveillance when we talk about Barrett's esophagus? We want early and accurate detection of dysplasia. We need to identify visible lesions which may harbor neoplasia, and risk stratification, and that's really going to be a crux of what we're going to talk about today, is how do we take that pool of non-dysplastic Barrett's and identify patients who will develop high-grade dysplasia or cancer, or may have a prevalent high-grade dysplasia or cancer, as we know our sampling techniques are not optimal. Dysplasia detection remains endoscopist and pathologist dependent, and our continued requirement for GERD as a prerequisite for screening, which is something that will change, is our largest limitation. So we may actually have created a situation where innovation and evidence for therapy of a disease has far surpassed our ability to diagnose it. And so the depressing part is, while that we become very effective in endoscopic eradication therapy for Barrett's neoplasia, we've made no significant impact on the incidence of esophageal cancer. So this is a long paradigm, but a very standard paradigm that highlights some of the questions that we need to raise in 2022. As we march down from screening and surveillance into some of our best practices and our high-quality exam, high-definition white light, targeted sampling of visible lesions, Seattle protocol, pathology interpretation, and then diagnosis. A lot of the questions on the right are things that I will address, but include things like the use of NBI, or optical chromoendoscopy, in improving our exam. And so the top part of this is really, how do we improve amongst the patients that we already see and do surveillance on? This isn't about increasing the screening paradigm, but it's actually about how do we do a better exam? And then how do our endoscopists and pathologists improve their diagnostic capabilities? As we get to the bottom, we have sort of different degrees of dysplasia or types of Barrett's that we see. And some of this are very straightforward. When we identify high-grade dysplasia or cancer, we send them for endoscopic therapy. With low-grade dysplasia and indefinite for dysplasia, these are some patients that sometimes need a little more information, and we're going to talk a little bit about the impact of TissueCypher in this role to really provide a pure low-grade dysplasia that we can confidently send for endoscopic therapy. And then sort of the biggest elephant in the room is our patients with non-dysplastic Barrett's over here. And that's where we need risk stratification. And we're going to talk about why the data behind a technology such as TissueCypher is going to allow us to identify that, and in a more important way, increase that denominator of patients we can treat. So why is all this important? What's the issue? I never have an issue with my patients. And so one of the things to keep in mind, when the denominator of patients we're looking at in terms of surveillance and screening is low, you're going to have practitioners who feel like they never see their Barrett's progress. But there is an issue, and this is one study that highlights this concept of a neoplastic detection rate or neoplasia detection rate. And this is something similar to what we might think of as an ADR adenoma detection rate. And this was in multiple centers in Minnesota, and it identified that 13% of patients had missed dysplasia. So what this highlights is our standard endoscopy, our standard biopsies, our standard protocol, as I outlined, is not without significant errors, right? And so we know that, but this is some data finally identifying this 13% number is very critical in terms of missed neoplasia. This was further emphasized by the idea of PEAK, or post-endoscopy esophageal adenocarcinoma. And this was a study published in 2021 in CGH, which looked at a large Medicare database. And again, the long and short of it, they identified this post-esophageal detection. So basically what we're talking about are missed cancers or missed neoplasia, and that again was at 13.7%. So what are we talking about? We're talking about the existing ability that we have with endoscopy, despite what would be perceived as high-quality exams, is still not enough for us to make accurate diagnoses, and we need some help from adjunct tools. So when we get into a high-quality exam, time is everything. This was some data out of the ESGE guidelines. There's been a few studies in the US looking at Barrett's inspection time, so how much time we spend in the esophagus identifying neoplasia. And again, visible lesions are the critical piece here. And they identified that greater than 1 minute per centimeter is ideal for this. And this is difficult. And as all of you as endoscopists know, spending a minute looking at every interval in the esophagus is very tricky. And so can we look at different adjuncts, and we're going to touch on some of these tools that may obviate the need for this. So this is a sort of laundry list, but identifies that high quality exam. I bring this into your vision, and not to review everything on here, but this is something you'll find not only in the recent AACG guidelines, but also in the very recent AGA Barrett's Esophagus Screening and Surveillance Clinical Practice Update that highlights some of the things we look at as a high quality exam, some of the things that might be looked at as quality metrics in the future, and a lot of the things that are used by our machine and our colleagues in the artificial intelligence field who are going to identify how we develop AI algorithms when we're talking about machine learning. This is just a typical example of what we see with visible lesions, very difficult here. The key piece and what has been highlighted by the clinical practice update in the AGA document is the use of NBI becoming standard of care. This is also highlighted in the ACG guidelines. And as you can see here, narrowband imaging on these subtle lesions provides a much better visualization of a neoplastic lesion in Barrett's. So as we move forward out of this, what should we be doing in practice, right? We talk about high definition white light. Now narrowband imaging is standard of care, should be utilized by everyone in all stages of diagnosis and screening and surveillance. Some of these other tools are still in early adoption and research only in terms of confocal endomicroscopy. AI is the sort of the buzzword, and it's probably the buzzword of this meeting for this conference. And we are in the process of developing these algorithms for the machines to understand how they can help us. But ultimately, this is going to be augmented intelligence and not artificial intelligence. This is going to be physicians and our tools and innovation that are going to help us identify neoplasia. But as I said, there's more innovation that's going to be a part of our decision tree. And before we get into that, one of the most important points here is this slide. When we looked at, and this is 2 different studies that looked at prevalent esophageal cancer, so patients who had diagnosis of esophageal cancer presented to a surgeon, they went back and said, how many of these patients actually had known Barrett's? And as you can see, the patients in blue never had a precedent diagnosis of Barrett's esophagus. Why is that a problem? Because if patients don't come to us now with GERD or swallowing difficulties, we're not going to identify that big piece of the puzzle. Again, I spoke to the denominator. We have to increase the number of patients we screen, and we have to increase the number of patients who have non-dysplastic Barrett's we treat. And so those are the 2 key pivotal points that we're going to focus on. And so understanding that the patients we are talking about today that we're dealing with is a very small piece of the pie in red here, is a critical piece of that. So this is the most recent document that I'm alluding to, and this is the 2022 AGA Clinical Practice Update. And it addresses those 2 buckets of increasing the denominator. First of all, screening with standard upper endoscopy may now be considered in individuals with at least 3 established risk factors for Barrett's or esophageal cancer. This includes male gender, non-Hispanic white race, age greater than 50 years, history of smoking, chronic reflux, obesity, or a family history of Barrett's or esophageal cancer. The key piece here is that GERD has now become just another piece of the risk factor pool and not a prerequisite of itself. And I think that's going to be critical, and I'll touch on that in a second. We talked about this one. I'm going to skip over this. White light endoscopy and chromoendoscopy are essential. Non-endoscopic cell collection devices, so things such as cytosponge, things such as EsoCheck, all these different devices that are tethered capsules or non-invasive, non-endoscopic cell collection devices can be considered. And these are things that we still need more data before we go mainstream and things that are going to be critical as we increase that screening pool. And perhaps the biggest piece on the other side of this denominator is risk stratification. And so the tissue systems pathology-based prediction assay, or TissueCypher, is going to be essential. And the data is now ripe at fruition in terms of demonstrating this tool being critical for us in practice to look at that pool of non-dysplastic Barrett's. So while the other 3 points on here help us identify more patients who have Barrett's, we're also going to increase the pool of non-dysplastic Barrett's. And not every non-dysplastic Barrett's patient is alike. And I think that's where this critical implementation of TissueCypher is going to help us understand who we can take from a surveillance pool and treat, and then perhaps even who we can take from a surveillance pool and increase or reduce their surveillance interval because their scoring on the TissueCypher assay is so low that their risk may be much less than a standard patient. So where do we stand in 2022 with this? We need to increase the denominator of patients with Barrett's and Barrett's-associated neoplasia. How do we do this? Number one, we talked about screening patients without reflux. We need to start looking at patients who don't have the typical symptoms of GERD, who have put us in the window where we just don't make an impact on the larger population of that pie chart I showed you. And then finally, the risk stratification of non-dysplastic Barrett's, which we're going to focus on in the last part of this talk, is how do we use this assay specifically to risk stratify patients. When we talk about screening, I want to shift gears here, and we're going to just touch a little bit about the screening paradigms available and then go right into the risk stratification piece. So this is just a summary of some data presented by Joel Rubinstein around clinical risk stratification. And perhaps the most important thing here is what these curves here show you, the sensitivity and specificity curves really highlight, is that these clinical risk stratification scores, and the one here that was looked at as the Kunzman score, significantly improved prediction for Barrett's-associated neoplasia over the presence of GERD symptoms alone. So no longer, and we looked at multiple studies that have been published out of this group, have demonstrated that the odds ratio of GERD alone is extremely low compared to using a larger clinical risk stratification tool. And ultimately, all that's pointing out is that reflux symptoms alone are not enough as a screening tool to decide who needs endoscopic evaluation for Barrett's esophagus. Ultimately resulted in a study that ideally helps us reduce the number of needles in our hay. So this was looking at 663 patients with esophageal cancer, and what they basically found is using the current societal guidelines around screening prior to this clinical practice update, that 54% of patients would not have been detected. And so that, again, highlights why that pie is so big. This chart just sort of depicts many of those non-invasive tools that are available or coming available. I'm not going to go through this laundry list, but these are things that are evolving. Research is evolving. We're discovering how to use them in clinical practice, and the update allows us to start looking at these in patients as a non-invasive tool in our clinics. One of the biggest advances in innovation for us, and it's reflected in the clinical practice update, is this tissue systems pathology assay, or TissueCypher. And so what is it? It really allows us to combine tools and combine different forms of science to make an objective assay for Barrett's risk stratification. The first part focuses on the use of a large panel of biomarkers and the idea of spatial biology. And Barrett's is a spatial disease, and some of the studies in the TissueCypher world have demonstrated not only the improvement of prediction of disease along the length of Barrett's, but also through time. As you know, Barrett's is a disease we sample over time, and we can determine progression that way. But this uses molecular biomarkers to detect changes in the context of the spatial tissue structure prior to some of those morphologic changes we see with standard pathology. Then the idea of digital microscopy, so this taken back, and vision systems that are used objectively and reproduce and analyze and interpret different tissue structures based on these biomarkers and features that are predictive of progression. Then, of course, the concept of AI, and where does AI fit here? Ultimately, you got to use these large data sets to train a computer, to train a system to recognize what is a progressor and what is a non-progressor. And that's where TissueCypher uses artificial intelligence to use on our system, on our tissue samples that have gone through what I've pointed out here from a biomarker assay, and then give us the idea of who is a progressor and non-progressor that we can translate into clinical practice and again, increase our denominator for therapy. And finally, one of the reasons we're talking about this and why this is a part of our clinical practice update is all about clinical validation. And TissueCypher has been through many rigorous studies that you're familiar with. There are 5 pivotal studies in terms of peer-reviewed publications that have launched this into prime time and really allows us to bring this tool to our clinicians in all practices to risk stratify patients with non-dysplastic Barrett's esophagus. So some of that data is presented here, and this was in the American Journal of Gastroenterology, and really looks at Barrett's patients. This was a blinded independent validation study looking at patient progressors and non-progressors with baseline non-dysplastic, indefinite for dysplasia, and low grade. And what you can see from here is that TissueCypher identified a subset of patients with non-dysplastic Barrett's that progressed to high-grade or esophageal cancer at a higher rate than even confirmed or vetted low-grade dysplasia by a standard pathologist or an expert pathologist. So the idea is that high-risk scores in patients with non-dysplastic Barrett's can support their early use of endoscopic therapy. So TissueCypher becomes actionable. So we can take some of the limitations we talked about that can actually lead to some of the peak or missed cancers and use them earlier in our patients with non-dysplastic Barrett's and create actionable paradigms for us in clinical practice. So this is the most recent TissueCypher pooled analysis performed by the Mayo Group. This was 552 patients and basically looked at the risk of progression to high-grade dysplasia or esophageal adenocarcinoma, again, inclusive of non-dysplastic progressors, indefinite, and low-grade dysplasia. And so one of the first things you see here without TissueCypher is that 5.8 for a higher odds ratio by an expert pathologist of low-grade dysplasia or vetted low-grade dysplasia versus non-dysplastic Barrett's. But then when we come over to this graph and we look at the addition of TissueCypher, what you see is an attenuation of that odds ratio. And basically that it's identifying that the use of this assay is giving you that purified or more vetted population. So it's even a better tool to find that population of patients with indefinite or low-grade dysplasia that we want to then put through endoscopic eradication therapy. The final piece of this, which is even the most important from my perspective, is look at the prediction of TissueCypher in this predominant group of non-dysplastic Barrett's as a predictor of progression, an odds ratio of 6. So we've reached a point where multiple studies have demonstrated that this assay, again, allows us to take our pool of patients, whether non-dysplastic or those confusing indefinite patients, and bring them to a much more definitive diagnosis and, again, an actionable treatment plan, whether that's surveillance, therapy, or extension of surveillance interval. In the last couple slides, I want to just talk about where does this all bring us to? And so we have a slide here that highlights a Barrett's care pathway. Everything we do is based on quality. Everything we do in medicine now is treatment paradigms in terms of these care pathways. And so some of the new things that will be changing as we move into the next sort of year here is this first box. Again, we will all need to work together to increase the denominator with screening. And so this idea that GERD now becomes one of the clinical risk factors that we're dealing with is something that we're going to further assess and study and identify. How do we effectively work with our primary care colleagues to find these factors and how many of these risk factors are critical? And I think what it's going to allow us to do is bring more people into the center of this pathway, into our clinics, to look at them from a risk stratification standpoint clinically, use non-endoscopic measures, some of these non-endoscopic tools for screening, and create a more comprehensive care pathway for screening. And then ultimately, as we were talking about here, is what do we do after we bring them through endoscopy, and how do we risk stratify this much larger pool of non-dysplastics that we find, and how do we better care for some of our indefinite and low-grade patients? And the use of TissueCypher here, again, as we highlighted before with some data and how mechanistically this looks at all these different hits that we take molecularly, but in a much more robust fashion, is going to give us a risk score that we can action. We can take action as clinicians identify the right population of patients we can now treat with non-dysplastic Barrett's. For the last 20 years, guidelines have been confusing around non-dysplastic Barrett's because we haven't incorporated a paradigm like TissueCypher that helps us objectively and not subjectively make decisions for our patients. So I want to end with this slide. This is bringing it all together. This is all about where we stand in 2022, which is so different than where we were in the last 10 years. We have many best practices in terms of screening and surveillance that are highlighted in this, again, most recent clinical practice update, whether it's preparation and some of the things we do with the endoscope, to inspection, the use of chromoendoscopy, speaking the same language in terms of landmark identification, adequate Barrett's inspection time. These are all things we can do, again, to identify the visible neoplastic lesions. But again, we're still hindered by some of the limitations of human intelligence, for lack of a better word here, and our sampling protocols, which include Seattle Protocol for 4-quadrant sampling. So ultimately, we need to move forward and use the tools we've talked about today. And specifically, the breakthrough here has been in risk stratification and the use of TissueCypher, again, to objectively identify our patients and overcome a lot of the limitations I showed you in that algorithm and identify these patients that we can now bring into a treatment paradigm and, again, reduce ultimately that risk of esophageal adenocarcinoma as we move forward. Thank you very much. And as we outlined, we will stop now and take some questions from the audience.